All right, so I'm going to walk us through, at sort of medium pace, really, dwelling on some particular aspects of the protocol and some of the logistic aspects. We've then got talks coming up from Francis and from Biljana, just to deal with some of the more practical aspects of how we get patients into the study, how we look after them, how we randomize them, and so on and so forth. Fully intending this to be an interactive session, so if something I'm saying isn't clear, or if you've got questions as we go along, then please do stick your hand up and we can have a bit of a conversation. There is a breakout session that follows the break, which happens in about an hour's time or something like that, an hour and a half's time, when we're going to be discussing in a bit more detail some of the sort of thornier aspects of the study. But even so, there's no reason why we can't get the conversation going now about exactly how this is going to work. So, excuse me, we've heard already this morning about profile, and I'm sure you've all read at least the profile protocol in outline. Essentially, this is a test of the biomarker that we've heard about this morning in patients with newly diagnosed Crohn's disease. Doing this through the medium of an open-label, randomized study. And I'm just going to show you the structure of the trial just now. The aim, of course, is to show that the biomarker is useful, that it helpfully identifies people who are destined to have a more refractory or relapsing disease course, and that by targeting them with our best possible treatments at this stage, that they get better outcomes. And conversely, it also helps us to identify the people who are destined to have a relatively fizzling or a quiescent disease course, and that they do just as well even without those aggressive therapies early on, and that thereby we improve the outcomes for this patient population. There are secondary objectives built into the study as well, looking at health economic outcomes, quality of life, and so on and so forth, as you might expect in a study of this size. Here's the schema, and James has already shown us a little bit of this, and I'm just going to walk you through this slightly slowly. As you know, we're aiming to recruit 400 patients over the next 2 years. We don't underestimate that that's a challenge, all right? And we're totally reliant on everybody in this room to help us to meet that challenge. The patients, once they've been recruited, have the biomarker assessed, and we're going to deal with some of the details of that in a minute. As we've heard already, the biomarker will divide our patients into the IBD high group, the red group, according to the talks that we've heard already this morning. These are the individuals who we believe are at increased risk of running a relatively refractory disease course. They're going to relapse more frequently if our biomarker turns out to be true, and they're going to have a much more tricky time of things. And conversely, there's going to be a bunch of individuals in the IBD low group who we predict are going to be in the more quiescent disease group. Okay? Our expectation is that across the population we get a roughly 50-50 split. We won't know that we get a 50-50 split until we're running the trial. The statistics are robust out to about a 70-30 split at the extreme end of things. And we may well see some departure from that 50-50 split. We'll see as we go along. But James, as I recall, you had some data which suggests that 50-50 is about right. Is that right? Yeah. In your original study, it looked more like the sort of 60-40, but the more recent data has evened us out at roughly 50-50.
Yeah, so it's important to say, as I said in my talk, that actually the PAX gene biomarker is not a perfect surrogate for CD8 sort of biomarker that we saw, but in all of the cohorts where we've looked at the PAX gene biomarker, both in the development and in the validation, it's been almost exactly 50-50, whether you're in the high risk or the low risk group.
Okay. So our patients then, in each of these groups, the high-risk group over here and the low-risk group over here, they then get randomized between step-up therapy, conventional therapy if you like, and top-down therapy. In other words, combination infliximab and azathioprine pretty much from diagnosis. That happens in both the high-risk group and the low-risk group. What we're anticipating, if the biomarker works and is useful, is that the individuals who are destined to have a much more rocky time and have frequent relapses, that top-down therapy will do them a lot of good. It will prevent those relapses from happening, okay? Whereas the individuals in the step-up group, we're rather anticipating that they will, much as with conventional therapy, continue to experience relapses and will, as it were, chase them up the hill with our gradually, actually quite rapidly escalating treatment. And we'll talk a little bit about the details of that in a minute, but it just goes conventionally from steroids to addition of azathioprine to addition of infliximab sequentially. All right. So we're anticipating that in the IBD high group, these guys will do well, top-down therapy, and these guys will do less well. Whereas in the low-risk group, again randomized 1-to-1, you might anticipate that top-down therapy is not going to be necessary in these people. These are the guys that you might expect actually They were going to run a fairly quiescent disease course anyway. They're the sorts of people that you give a course of steroids to, they get better, and actually you don't really need to escalate their treatment again. So they may not need the top-down therapy, and that we're expecting the delta in this group actually to be rather small, all right? And the basis of the study is to compare the deltas between this group, where we're expecting a big delta, and this group, where we're expecting a fairly modest-sized delta. And if we demonstrate there's a big difference in those deltas, essentially that tells us that our biomarker works, that it is appropriately targeting aggressive therapy in the people destined to have an aggressive and relapsing disease course, and sparing individuals who are destined to have a quiescent disease course from the need for those sorts of treatments. So that just gives you an overview of the structure of the study. There would be any number of different ways of designing this trial, and believe you me, we discussed most of them 5 years or so ago, until James tripped over the literature in the oncology sphere of things, which tells you how to do biomarker stratified studies. And this is the design. I think we'd actually arrived at this independently at the point that we actually dug out this literature and found that this is exactly the right study design to run this sort of biomarker stratified trial. So, recruitment. We launched in Cambridge in December. We were able to get a patient in fairly quickly. I know, talking to a number of you out at lunch today, you've got sort of patients stacked a little bit, ready to go into the study, which is fantastic. It really works well, and Francis is feeling the heat now to get you open so that you can get those patients you've got stacked into your studies and get yourselves launched. I have to say our own experience is that in the context of running clinical trials, if you can get patients in early, soon after you've launched, it makes a hell of a difference. The ones where you don't get a patient in the first 3 months, we hardly ever recruit to. If you can get them in early, you're up and running, you get a feel for how the study works, and off you go. So please do be looking out for those patients, even if you haven't yet had your SIV, because, as we said earlier on, within 3 months of their diagnosis, they can come into the study. So please do begin to think about the study at this stage. We put 2 in fairly quickly when we opened at the end of December, just before Christmas. We've not had any more in yet, but we've got a couple, I think, in the wings who are due to go in. Importantly, yes, we launched King's Lynn 2 weeks ago. Alan, were you here? And Ellie? Yeah. So these guys launched, and you've put somebody in already, right? Yesterday. Tell us how that went.
I started the coloscopy yesterday with the video capture not working, and magically Ellie fixed it by the time.
Fantastic. Okay, so that's an important point, and we'll come on to that in a little bit later on in the session. But where possible, if you identify people who may have Crohn's disease, please do, when you're doing their colonoscopy, capture that colonoscopy on video, because we really want to be able to use that later on. We'll be dealing with that in a bit of detail later on. For those of you who are good at maths and you can work out 400 participants over 2 years at 50 sites, you'll have worked out that it's each site 5 per year, i.e. roughly 1 patient every 2 to 3 months. But this isn't a limit, right? You can recruit as many as you want. It's kind of competitive recruitment in the industry parlance, but we really just want people to recruit well into this study effectively.
Well, it's 4 per year, if you
QED. There we are. So having dealt earlier on with the sort of the objectives of the study, now to get on to the actual primary and secondary outcomes. The primary outcome is sustained surgery and steroid-free remission throughout the year that the patients are in the study, through to week 48. And the secondary outcomes that we're going to be looking at are the mucosal healing, and this is why it's important, obviously, to have the colonoscopies videoed, a quality of life assessment as done by IBDQ, and also an assessment of disease burden, and a hierarchical, and Simon, who's our Simon, put your hand up. Simon's our statistician on the study, has made us clinicians focus our minds on exactly how we organize this in a hierarchy of outcomes, a number of flares, cumulative steroid exposure, steroid-free remission, a number of hospital admissions and operations, to give us a sense of the disease burden between these two groups, as well as the primary outcomes that we've got listed. On to the inclusion criteria. As we've said a number of times, Crohn's disease diagnosed within 3 months. And the point that's already been made, and I think this is an important point, even if your patient has had a course of steroids, they can still come into the study. Now, they need to have completed their course of steroids within the 3-month interval, and to have, importantly, have got off those steroids, and that their Crohn's disease has again flared. This is the basis on which the biomarker is going to be run. If they've not got active symptoms, then the biomarker doesn't work as well. So they need to have got active symptoms in order to get into the study, and they need to be off steroids as well. Oftentimes, and we'll again come on to this a little bit later on, we will find that patients have come into the system through a variety of different routes. They may have met a surgeon in the colonoscopy department who said go on a course of prednisolone. They may have come through their GP who started them on a course of steroids. Please don't dismiss those people as not being eligible for the profile study. They can still come into the study, but you just need to keep a good eye on them, keep tabs on them, and just see what happens to them. Age 16 to 80, so fairly broad, obviously. They need to have moderately active symptoms of Crohn's disease. So one of the points that was raised at our data management committee meeting, and we've been phenomenally lucky, I have to say, with the people that we've managed to recruit to the trial steering committee, which includes Geert de Haans from Amsterdam, who's been very supportive of our group, a guy called Bob Gray, who's the leading biomarker stratified statistician globally from Harvard, who's helping us on that committee, and Severine Vermeer, who's on the data management committee. One of the points that Severine raised, I think very sensibly, is be careful that you don't recruit too many people with too mild Crohn's disease. And I think that's a really important point for this study. If they've just got a little bit of bellyache and their bowel function is normal, or maybe their bowels are opening 3 times a day, but they don't have any constitutional symptoms at all, and you do a colonoscopy and there's just a few aphthous ulcers and a bit of erythema, I don't think those are the people that we want to put into profile. Okay? We don't want to end up with 400 patients with mild Crohn's disease at the end of this study. That would not be a good outcome for our study. We want people with, as it were, proper Crohn's disease. And we all as gastroenterologists recognize what we mean by proper Crohn's disease, and with significant symptom burden and significant objective evidence for inflammation. So this translates as in the protocol and parlance as a Harvey-Bradshaw of 7 or more. Those of you familiar with the Harvey-Bradshaw will recognize that does require a sort of significant symptom burden. But again, just watch out for those people where the Harvey-Bradshaw has been purely driven by maybe purely driven by bowel frequency, maybe in somebody whose bowels open 3 or 4 times a day at baseline and they've gone up to 5 or 6 times a day and they've just tipped over and the colonoscopy doesn't look that bad. Again, clinician judgment. We're totally reliant on this study for you guys to do sensible things and put patients that you recognize as having significant Crohn's disease into the study. Endoscopically, we want people who've got at least moderately active Crohn's inflammation. James, I've just seen James Lindsay arriving. Where's James? James, here we are. Sorry. Yes, noted. So James is going to give us a talk on SES-CD scoring in a minute, which will put all this into context for those of us who are less familiar with the SES-CD, and I absolutely hold my hand up and put myself in that bracket. But this is significantly active Crohn's. This is more than a few aphthous ulcerations. They need to have a raised CRP or a raised calprotectin. Now, I don't know how quickly you get your calprotectins back in your place, but in our place it can be a little bit slow. So I suspect that in the majority of situations this is going to be a raised CRP for most of us, and we may not actually have the calprotectin back at the point that we do our baseline visit. I think if you've done an endoscopy that shows significant Crohn's disease and they've got a raised CRP, then you can be confident that their calpro is going to be up anyway. But don't worry too much if your calpro is a little bit slow coming back. And of course, being newly diagnosed, they need to be immunomodulator and anti-TNF naive. It's possible, of course, your patients will have rheumatoid arthritis or Angst-Bond and already be on anti-TNF therapy. I'm afraid those guys can't come into the study. Please put your hands up if any of this isn't clear as we go along. Here we are.
Nice. Those patients who have completed a course of steroids, relapsing, so do they need a second colonoscopy to get all these ticks for this inclusion criteria? Or can you take the first colonoscopy active disease as a proxy?
We don't want you to have to repeat the colonoscopy for the trial, I think is the basic point. So if you've got a colonoscopy that's clearly demonstrated active disease, maybe it was done by your colorectal surgical colleague who didn't think about the profile study, and you put them on the course of steroids, and then you meet them. You don't need to repeat the colonoscopy in order to get them into the study. If you're happy to do it and the patient is happy to do it, then I think that's fair enough. Or if there are diagnostic uncertainties, then yes, please do capture that. But we're keen to avoid putting patients through unnecessary investigations for the sake of the study. They do need to have some investigations at the end of the first year, of course. So let's not overburden our patients, but play that by ear and do sensible things. Anjan.
When you say raised CRP, is it any raise?
Any raise, just above your upper limit of normal. Just above your upper limit of normal for your place. Okay. Exclusion criteria. We don't want people with ulcerative colitis in the study, although it would probably work for them in truth, but don't put them in if they've got ulcerative colitis or indeterminate. Perianal fistulae or active perianal sepsis, of course, these are people who you're going to want to put on azathioprine and infliximab plus minus anyway. So again, we can't put them in the study. It's not that the biomarker wouldn't work in those individuals, it's just they wouldn't be appropriate for this sort of study. Here's an important point, and again, we're going to rely on you as clinicians just to use common sense here. They can come in, so exclusion criteria is obstructive symptoms and radiological evidence of obstruction, or colonoscopic evidence of obstruction, such that you as a clinician feel there's a significant chance this patient might need a surgery because they're going to obstruct, okay? Again, we're going to rely on your judgment here. If they get a bit of abdominal pain and you do an MRI scan and there's a little bit of narrowing there, but hey, this looks like inflammatory disease activity and that's why they're getting their abdominal pain, you don't think that they're a particularly increased risk of needing an operation, we're happy, very happy for those people to come into the study. On the other hand, you do an MRI scan, there's a big long fibrotic stricture there with upstream dilatation and inflammation markers that are only marginally elevated. Those probably aren't the people that we want to put into the profile study. I don't think we're going to lose very many like this. These should be a newly diagnosed population, but just to bear that in mind. Tarek.
Sepsis or perianal fistula without any sepsis? Is
Essentially any perianal fistula or sepsis. So the point here being that we don't want to put people into the study where you as a clinician will feel that they need to be on azathioprine and or anti-TNF therapy anyway to manage their Crohn's disease. Because of course if they go into the step-up arm of the study, they will just get a course of steroids and you might be sitting there thinking, this doesn't feel quite right, having a patient just on steroids who actually I probably would normally put on azathioprine plus minus infliximab. So just to be clear about that. Just wait for the microphone because we're video. The reason we're a bit insistent on the microphone is that we're videoing this for people who can't make the meeting and they won't hear your questions unless you've got the microphone.
What about patients who have on ileoscopy don't have that much information, but an MRE shows that there is quite a lot of disease beyond the extent of the ileoscopy?
Yeah, so in fact, again, a nuance for this study, and it's a good question, the nuance for this study is that we want people who have got endoscopic evidence of inflammation. So for people who have essentially got proximal small bowel disease, but without ileocolonic involvement that you can't see with a colonoscopy, we don't want them in the study either. So it's a relatively small fraction of the Crohn's population that you'll appreciate. It's probably 2 or 3%, that sort of thing. But yeah, we want the readout from the endoscopy that what we're doing is working here. Obviously, any contraindications to the study medication, so Hep B or Hep C, tuberculosis, malignancy, pregnancy or breastfeeding, although it doesn't matter if patients do get pregnant in the course of the study, we shouldn't have them pregnant or breastfeeding at study entry. If they've got serious and significant medical and psychiatric illness or are otherwise unable to comply with the protocol, we've had a guy here, one of our American patients who is moving back to the States in 6 months' time. He's devastated. He really wants to join us in the study, but he can't. He's going back to the States in 6 months' time, so he's not going to be able to complete the protocol. So obvious things like that. Okay, so here's a sort of a view of a patient pathway. In the first instance, an ideal scenario, and again, one of our breakout sessions later on is going to be how do you actually identify patients in your own place to bring them into the study. At the point of referral, and I don't know how many of you actually triage your new patient referrals, perhaps try and have somebody who spots these patients as they come through the system and identifies them and emails. I don't know if you've got a study nurse who's leading the project in your place, but pop an email through to them saying, Joe Boggs over here, he looks like he might be possible. Can you please keep an eye on this person? The patient comes up to the clinic, and of course in the differential diagnosis, at the point you're saying we think this might be Crohn's disease, you can say to them, look, this might be Crohn's disease. If it turns out to be that, we are running this interesting new study of a biomarker, and it's something that you might be interested in. The way that I present this to patients, I say, essentially, if you join the study, you will be randomized between conventional treatment and a sort of super-duper version of the treatment. I appreciate that the ethics people might be a bit cautious of that, but how else do you describe this thing? I just say it's the best treatments that we have in Crohn's disease from the beginning, and we don't know yet whether this is going to be a safe or a useful strategy to do. And I think we have to be honest with patients about that. That's the fundamental nature of the study. From the patient's point of view, they needn't get bogged down in the nuances of a biomarker. Essentially, all they're seeing is they're going to be randomized between conventional treatment and top-down treatment as they come into the study. And it's worth mentioning that to them at the first point that you meet them. You then book the patient for a colonoscopy, which you record, importantly, And if that confirms Crohn's, that looks like it allows them to meet the eligibility criteria, you can give them an information sheet about the study and maybe arrange for them to come back 2 or 3 days later. And obviously you've primed them already about the study. This isn't new information to them, hopefully. And they can then come up to their screening visit a few days after their colonoscopy. You can take the biomarker blood test and do all the usual sort of screening type things. And importantly, you can start them on steroids at that point. Okay? So there's no real, or there shouldn't be any real delay in your starting these patients on their course of steroids. They can start it as soon as their blood marker has gone off. Any questions about that? Okay. So, as you can see, if you are particularly going to shepherd patients into this study, if they're willing to do so, the referral arrives. This is partly how we're doing it here in Cambridge. If it looks very likely they're going to have Crohn's disease, actually we book them a fast-track referral. They come along and they see Nuru in the clinic next door to me. They then get booked to a rather fast-track version of endoscopy, which we record. And at each step, we've been mentioning the study to them. And if they're then happy to come into the study, a couple of days or 3 days after their colonoscopy, we've sent off the biomarker and started them on a course of steroids. Actually, so from the patient's point of view, they actually get quite a good deal compared to the normal drifting through the system, and it takes 3 weeks or 4 weeks to get them into the clinic and so on and so forth. I think that's fair enough. What actually happens, of course, is the patients get referred. They come into one of a myriad different routes, A&E, colorectal surgery, what have you. They get started on steroids, of course, and they can still come into the study. This is the important point, as we've discussed already. Just keep an eye on them, track them through, mention the study to them, say if your symptoms flare up, let us know as you're coming off the steroids. They do need to get off the steroids completely to do the biomarker test, but that they can then still come into the study. Info to collect at the screening visit, the results of the colonoscopy and including the video, the MRI scan, which doesn't need to have happened by that point. We've got a big backlog here, I'm sure you have as well. That can happen a little bit after they come into the study. They can have already begun their treatment and still get that MRI scan done. And then the quality of life measures. Samples that get collected, all the usual stuff, and a pregnancy test for ladies. And then the samples that get sent centrally, a PAX gene tube, and the patients get given a couple of packs, and Nuru and Harvey will show you the boxes that get sent through the Royal Mail. So the patients get given the pack, they go off, and, of course, and do the poop in the privacy of their own home, and then pop those samples in the post to come through centrally. This is the baseline visit, which will happen roughly 2 weeks after their initial screening. Bear in mind, they were started on steroids at the screening visit. They come back. You re-record their symptom index. They may well be a bit better now because they've been on steroids. You record all the usual stuff about medical history and con-meds and so on and so forth. Quality of life measures as well. You send off these blood tests. Of course, at this point, and Francis will talk about this in a minute, you now have the results of their biomarker assessment and you randomize the patient at the at the baseline visit. You randomize the patient at the baseline visit, 2 weeks after their screening visit. So they will now be randomized between accelerated step-up therapy, an 8-week course of prednisolone. As we said, that's already been started at the screening visit. If by the time you see them at the baseline visit, 2 weeks after screening, if they're still significantly symptomatic, bear in mind these are newly diagnosed patients with Crohn's disease, having been put on prednisolone 40 milligrams per day, most of them should get better on that regimen. So when you see them 2 weeks later, we're anticipating the majority of them will be feeling better. But if they're not, we would like you to book them another visit 2 weeks later. Don't adjust their treatment at that point, okay? Book them another ad hoc visit 2 weeks later, and if they're still significantly symptomatic at that point, then they go on to the next step, as it were, of the study. So they're now going to bump up their steroids again and be started on azathioprine, okay? This is a 12-week course of azathioprine. Of course, this 12-week course of prednisolone, I beg your pardon, to give the azathioprine a chance to work. If for some reason they're intolerant of azathioprine, then you've got the options of low-dose mercaptopurine and allopurinol or methotrexate, according to your own judgment as to what the right route to go is there. Of course, you'll have checked their TPMTs as well, and it may be that if they TPMT null, that you want to put them on methotrexate. All those options are there and available to you. If their symptoms remain refractory to a 12-week course of prednisolone and the immunomodulator, or if they get better but then get worse again, then they go to flare 2 step with the addition of infliximab. Okay? So this is a relatively accelerated step-up program. Probably this is typical of what many of you in the room are doing here now. It may be a little bit faster than what many of you in the room are doing, but that seems to be reasonable. We're trying to slightly future-proof this study to anticipate what medical management of Crohn's disease will look like as a standard thing in 3 years' time or 4 years' time. Anjan?
If the DPMD isn't back at that 4-week period, what happens then?
So we want you to do whatever you would normally do in your place with regard to azathioprine.
What we normally do is use a small dose and wait for the DPMD.
And I think that's a completely reasonable thing to do, and we would probably do the same thing here. If they have a flare after they've been started on infliximab alongside azathioprine, then they get another course of prednisolone. Okay? If they've been randomized to top-down, they've still got their 8-week reducing course of prednisolone started at the screening visit. They've now been randomized to top-down, so beginning infliximab roughly 2 weeks after their baseline visit, just to give you a chance to get that booked in. And in fact, we would recommend that anyway, all patients who come to their screening visit and sign up to the study, we actually book them a slot on our infusion bay and then cancel it if they don't need it, if they get randomized to step up. Just to give our infusion bay a 4-week lead time on the thing, because actually trying to get people in with 2 weeks' notice is a bit of a crush in our place. I suspect it may be in your place as well. They would much rather book it and cancel it than try and shoehorn somebody in at 2 weeks' notice. In patients who are randomized to top-down, they can be given a rather accelerated rate of wean off their prednisolone. As we said, infliximab started 2 weeks after their randomization visit, after their baseline visit. It can be up to, is it 3 weeks or 4 weeks, Francis? Up to 3 weeks if your infusion bay is full up. If they have a flare on combo therapy, then they get a course of prednisolone. So this is an important point. We don't want you to optimize your doses of infliximab and double those up and what have you. That's not what Profile is about. I appreciate that that may be what you're going to be doing, and you may be already doing that now or in the future. Please don't do that for this study. Of course, the course of prednisolone is what dings the primary endpoint, and if they haven't done that, they won't ding the primary endpoint, but they will have flared, so that'll cause trouble. I appreciate that may not be completely what you do at the moment, but please bear with us, and I hope you find that acceptable with regards to your study. There's an important asterisk down here, which is that if patients on the top-down arm, if they've not adequately responded by week 8, so this is in other words, so week 8 of the trial is 6 weeks after their dose of infliximab. So if they've not responded adequately at the point they come and visit you for their 3rd induction dose of infliximab, they can be scheduled for another dose of infliximab 4 weeks later, an extra dose of infliximab 4 weeks later. That'll be funded through the trial. As you're aware, the infliximab is being purchased by the Predictimmune and by the Wellcome Trust to run this study, and they can have that extra dose, provided their infliximab level is less than 20 on a blood test taken at that point. So please do ask your patients, ideally, look, if you're not getting better, let us know, because we'll want to check your infliximab drug levels prior to your week 8 infusion, so that we can, if necessary, instigate this extra dose. Sean, you've got a question?
Thanks, Miles. Occasionally, we will all have had patients who have had reasonably to them intolerable side effects with steroids. And how much wriggle room is there if you've got a patient who you think's had a torrid time on 40 and you don't want to put them back?
I think I'd probably need to give that a bit of thought, but I think if your sense is that they did okay at 25 and you're happy as a clinician to put them back to 25 and the expectation they'll get better, we could probably run with that. We'd probably run them for a bit longer on their 25 milligram dose just to resync them, as it were, so they don't just end up with a short course of steroid. But I think that would be reasonable.
Is septin prophylaxis is allowed when they're on triple therapy?
You can do what you like in your own place. So if you would normally put patients on Septrin as prophylaxis in this situation, please feel free to do that.
And second, is it biosimilar or is it Remicade we are using?
It's biosimilar.
Biosimilar.
So this is the scheduled visit, and we tried to minimize extra study visits, as you can see here. So there are 6 visits over the course of the year scheduled for the study, and where possible we've tried to coincide those with their infliximab infusions. As you can see, the screening visit is week -2, baseline is week 0, and with the infliximab scheduled there. You do have copies of these slides. This presentation is being videoed as well for anybody who needs to take this back to your own place and show other people who may be involved in the study exactly how it's designed to run. These are the data points that are going to be collected at each of the visits. The week 4 visit, we collect all this fairly standard stuff and send off these fairly standard blood levels. In patients on thiopurine, please check those levels as well. And you are allowed to adjust the doses and optimize those doses as time goes on, and please do that according to what you would normally do. Here's the week 16 and 32. Have I missed off one? No. Week 16 and 32, again, collecting all the usual sorts of information, sending off those bloods and additional samples which get sent centrally at those time points. And then the end of study visit, again, all the usual information, but now we're booking them or wanting to do a colonoscopy and an MRE. Francis sensibly made the point on an SIV that I was on the other day, probably sensible to book these things actually at the point you do the baseline visit, so that you don't forget and you're not trying to then shoehorn people into your radiology department in a year's time at short notice. So worth getting these things booked up well in advance. And then the usual bloods and centrally sent stuff as well. SAEs, and this is an important point. One thing, a sort of philosophical point, if you like, this isn't a CTIMP. We're not testing these medications. These medications, of course, are all well used in Crohn's. We fully understand the spectrum of side effects that we get, so we're not recording every sort of itchy rash or headache or sneeze that a patient gets as you would do in an ordinary commercial drug trial. We just want to know about important things for this study. What do we mean by that? Well, SAEs, of course, we do need to record these. Death, life-threatening, hospitalization, the usual things that those of you familiar with commercial studies are involved in, significant disability, congenital anomalies. Adverse events, we're really only interested in things that relate directly to the drug therapy because we want at the end of the study to be able to say, look, in the round, top-down therapy, not only did your disease do better, but actually it was safe as well. And our ability to say that, of course, will be markedly impaired if in top-down therapy everybody got pancreatitis and lymphoma. Their Crohn's might have been well behaved, but actually in the round we didn't do them any favours by doing that. So we want to capture significant adverse events. Of course, malignancy, including lymphoma and skin cancers, and sepsis requiring hospitalisation. We don't need to know about the odd cough and cold, but if we're serious enough to bring them into hospital, let's capture that. Thiopurines, of course, pancreatitis, significant myelosuppression, and significant liver toxicity. Methotrexate, pneumonitis, myelosuppression, liver toxicity in pregnancy, and then anti-TNF demyelination, active TB, and anaphylaxis. All right, nearly at the end now. We're just going to discuss a few top tips, and we can discuss these in a bit more detail in our breakout session a bit later on. Spread the word around your place, and I've heard already, Alan, I think it was you talking earlier on, just let your surgeons know, get the registrars know, any clinical specialists you've got operating in your endoscopy departments, please spread the word about the profile trial. We're looking out for newly diagnosed Crohn's patients, and tell them to let you know and give them the contact name for whoever is the key point person in your place who's going to be running the study, so they know exactly who to let know. We're all familiar with the idea. You meet somebody who's perfect for the study, a week later you can't remember their name, you can't track them down, you're doomed. So just send them an email at the point that you first see that triage letter or you do that colonoscopy, send that email so that you've got a trail and you can track back and find that patient for the profile study. And encourage all of your colleagues to do the same. I don't know about you, but I work with a bunch of goldfish sometimes, and I'm happily one of the goldfish community as well. I forget studies within minutes of being told about them, so keep reminding people about the study on a weekly basis. Constantina, my lead research nurse over there, is smiling enigmatically, sound in the knowledge that each Wednesday and Friday clinic she has to come tell me all of the studies that we're recruiting to on any given day. So do keep reminding people, keep refreshing their memories. We were talking about, Alan was talking earlier on about putting up a reminder notice in the endoscopy department, buy people a box of Bickies or whatever it takes just to encourage people to think about the studies. We'd be very grateful if you could do that. On the referral letters, you all know how to diagnose Crohn's disease, but the guys that you invest the extra effort in, they don't just have abdominal symptoms and a sort of suggestive thing. Of course, they've got raised inflammatory markers, or they've got a family history of Crohn's. Slightly less predictive in our experience is the very raised Calpro, but you know, if you've got somebody with significant abdominal symptoms and a family history and a raised CRP, listen, these guys are going to be good for the profile study. These are the people that we are fast tracking, or Neuro is fast tracking into our clinic to take a really careful look at. Try and get them into your clinic, don't just dump them into whoever they were going to see, and begin the conversation early, as we've said already. And we do invest this extra effort in people who are highly likely to have Crohn's. For people where they've just got a rather long IBS type history and a modestly elevated Calpro, listen, we keep an eye on them, but we don't invest extra effort. We're mindful everybody's only got a finite amount of time in their day and their week. So invest the effort where it's going to be most rewarded. Don't chase down every Calpro that's just slightly out of the normal range or what have you, because you'll just end up getting fed up with a lot of people you fast track through and who've got IBS and do colonoscopies on them, and you'll just get a bit fed up. Record the index colonoscopy, as we've said, and James is going to explain to us how the SES-CD works just now. Do remember to just consent the patient to the fact you're going to video their index colonoscopy. They're not in the study at that point, so our consent doesn't cover that index colonoscopy. I think it's fine actually if you just put colonoscopy plus video recording on the handwritten part. Many of you have got a pro forma, a pre-specified version of that on your consent form, so just tick that videoing box. But if you haven't, just mention you're going to video it on the written bit. We've mentioned starting the steroids as soon as the biomarker is taken, and book an infusion slot at the screening visit and cancel it if you don't need it. Okay, that's it. Thank you very much indeed.